freeze. One is the chordate width to the ratio with the right lobe width, and this is pretty specific. Now, nodularity, it is very important for the sonologist, the radiologist, to see the surface of the liver. It's easy to see it as in this image when the patient has ascites, but when the patient does not have ascites, it is not usually commented well upon. And those are the patients who you suspect of portal cirrhosis, and you want that information from. So surface nodularity is very specific and very sensitive as well. The liver echo texture is important. It is again a subjective opinion. Unless it is very highly coarse in echo texture, you will get different reports from different sonologists for the same patients in the same period of time. But liver which has multiple nodules, which may be regenerating nodules and dysplastic nodules, though that's a sign of obviously a long-standing cirrhosis. So other signs, telltale signs of portal hypertension you have to look for are ascites, splenomegaly, varices, and the last point of reverse portal flow. Now, when you order an ultrasound for cirrhosis, this is a point which we as radiologists usually do not look into. We don't see the portal flow. So if you are not getting that information, I think you should ask for it from your radiologist once you get the report. Doppler of the portal vein, flow reversal, the collaterals, the prominent hepatic arteries within freeze flow is another sign, and hepatic veins which are thin, and there is loss of physicity in them. So all these are technical points, and you should know them as physicians, because you should expect that information in a report. So liver, again I'll repeat the points: liver surface irregularity, echo texture nodularity, the size of the liver, the volume distribution, is there ascites, portal vein diameter, the direction of the blood flow in portal vein, is there splenomegaly, what are there varices present, and obviously is there any mass, which we'll touch upon in the next part. So what happens on the ground is, as mentioned before, that the reliability of ultrasound reports in general is pretty questionable. There are few people who do it in the right way, few people who have the right equipment, and there is a communication gap between the ordering physicians and the radiologists. What are the solutions that we should be looking into, because ultrasound is an extremely important modality for surveillance, and there is a huge gap between in this field. So more frequent interactions and feedback. When you get a wrong report, you should be writing the question that hasn't been answered, and that should go back to the radiologist, so at least he gets the feedback. You should demand, encourage and assist in development of disease-specific templates for reports. So you can get, for example, in all cirrhotic, potentially cirrhotic patients, there should be a heading in the report about the direction of the portal flow. And apart from that, other stuff as well, as I've mentioned before. You should publish that data, and obviously MDTs should be done with the radiologist, so the feedback is there. And this is just a simple point-wise slide in which you can see the different things that should be mentioned, preferably be mentioned in headings, so you get an overview of the patient's condition, the liver and the cirrhosis. Now we come to HCC and cirrhosis. Now in Pakistan, obviously the data is not that much available, and the condition and the situation is also not that good, as is in the rest of the world for surveillance in ultrasound. Surveillance is crucial. A randomized controlled trial indicated that biennial screening reduced HCC mortality by 37%. This is from the ASLD. And 3-year survival nearly doubles if patients follow a strict surveillance program. There are obviously many different surveillance regimes. and usually the one being followed are an ultrasound with that protein every 6 months in high-risk patients. So what is the state of HCC surveillance according to different studies in Pakistan? Unfortunately, 8 out of 10 patients are diagnosed when they become symptomatic. That means that they were not under surveillance, and when they become symptomatic, that's when they're diagnosed. And 2 out of 10 are detected either incidentally or under surveillance. So it's less than 20% that are detected when they are under surveillance. And as low as 10% patients in Pakistan with risk factors of HCC undergo regular screening for various reasons. So again, let's talk about what are the ground realities. Are all cirrhotic or patients, or are all patients at high risk registered in a regular screening program? What is the patient compliance? What are the causes of the patient being non-compliant? One of the main causes obviously is lack of knowledge about the potential disease which they can face in the near future. And ultrasound detection rate of early HCC is obviously not that good in the world, and especially here in Pakistan, because of lack of dedication, lack of training, as mentioned already, lack of expertise and proper equipment. What are the solutions that might help in this regard? Informing and educating patients about the HCC and importance of regular screening is extremely important, and one has to invest time, energy, if not finances, in this point. Establish a local and regional registry for patients who are on high risk. Interaction with and feedback to the radiologist that you're sending your patients to. And involving the pharmaceutical industry or other stakeholders to help develop a system to follow up patients who are on a screening program. Now, in this age of technology, one can easily come up with solutions, novel solutions, in which you can offer a screening program to the patients, and then obviously publish your data that you've come up with. I think it's stuck here. And it's important that how do you know that your radiologist that you're referring to is actually getting better? You know when he is getting better when you start getting early HCCs being reported from your radiologist. Now we go on to CT. When do you do a dynamic CT? For diagnosis, number one is for the diagnosis of HCC. When you do find a lesion in the liver, go ahead and order